Going to be talking about ACL reconstruction with extra-articular augmentation, and I want to give a historical perspective. There's a ton of info in this talk. I think it's fun. Hopefully, you don't find it too boring, but we will talk about kind of how we got here, talking about extra-articular augmentation because it's not new, and it's kind of cool to go over the historical perspective here. So, let's start with a clinical vignette. 16-year-old female has a knee effusion. She's a soccer player. She has a high-grade pivot shift, 2B Lockman, lots of instability with anterior drawer. MRI shows an ACL tear and a pivot shift bone contusion with increased signal intensity at the anterolateral complex. Um, what would you do for her? I think a lot of us would do a BTB. A lot of us would do a quad. Would you offer her any other procedures? Why or why not? I want to introduce this concept of anterolateral rotatory instability. And as we know, the ACL provides translational stability, but it also provides some rotatory instability, which becomes important. And the basics here is the way I think about this problem is that some ACL reconstruction is a great surgery. It has a low failure rate, but some people are prone to graft failure after reconstruction. Pick your favorite database. There's various, numbers and risk factors reported, but most people agree that young, athletic, ligamentously lax individuals, increased tibial slope is a risk factor for ACL reconstruction failure, small notch, other associated injuries. And the idea here is that some of these risk factors can't be modified, like ligamentous laxity, and some are difficult to modify, like doing a tibial osteotomy for everybody with increased tibial slope. And the idea is that ACL rupture causes translational instability, but also rotational instability. And what can we do to prevent those re-ruptures in high-risk people? So there's been some talk about the anterolateral complex. It's kind of had a revival in the literature somewhat recently. And what we're really talking about is this anterolateral complex, which is the anterior longitudinal ligament, the iliotibial band, the lateral meniscus, and the anterolateral capsule. Um, and these provide some rotational stability. And this has been likened to, if you think about controlling a steering wheel, it's hard to control rotation at the center of the steering wheel. It's a lot easier from the periphery of the steering wheel. And that's kind of how the thinking at the most basic level is for these extra-articular augmentation procedures. So, in cadaver studies, we know that when the anterior longitudinal ligament is resected, it causes increased tibial rotation. Um, in Also in cadaver studies, in ACL deficient knees, um, that they with if you transect the iliotibial band or the anterior longitudinal ligament, you also get increased tibial rotation. With you can measure this with a pivot shift test, and this is not something that's just theoretical. People have correlated high-grade pivot shifts with poorer outcomes and increased risk for failure following ACL reconstruction. So um, the idea here is that there's some structures in the anterolateral knee that help impart rotational stability, and perhaps there's some residual rotatory instability that could put us at a major risk factor for ACL reconstruction failure or even bad outcomes after ACL reconstruction. So the idea is that we can improve rotational stability and prevent failure after ACL reconstruction by performing extra-articular procedures in high-risk people. In the literature, these are called LEAPS, lateral extra-articular procedures. These days, we're talking about two major ones: the anterolateral ligament reconstruction, which is more popular in Europe, and the lateral extra-articular tenodesis, which is more popular here in North America. Um, this is just a picture of what we're talking about with anterolateral ligament reconstruction. Um, Anterolateral ligament rupture is causes a Sagan fracture, pathognomonic for an ACL tear. And what we're doing here is we're tacking down a graft on the tibia in between Gerdy's tubercle and the fibular head, and we're tacking it down on the femur just posterior and proximal to the lateral epicondyle. And this is a cool graft because it is theoretically an anatomic graft. So that's what proponents of this graft like. They say we're reconstructing a ligament that exists in the native knee. Um, for a lateral extra-articular tenodesis, we take a strip of the iliotibial band, we whip stitch it, we pass it under the LCL, or or sometimes we don't. You tack it into the femur, and you can fold it back onto itself. And this is the type of extra-articular augmentation by far that most commonly is seen in the United States. I think this is a cool quote because when I started looking at this talk, um, it's interesting that these are not new things, and I like this quote that there is no present or future. There's only the past happening over and over again now. It's not totally true, but it certainly rings a little bit true when it comes to this topic. So let's talk a little bit about the history of ACL reconstruction. Um, we'll breeze through this because I think it's fun to talk about. Um, Shout out to Galen in ancient Rome. He was the first to identify a ligamenta genu cruciate on his book on the usefulness of the human body, which I think we can all agree as the as orthopedic surgeons is pretty useful. And He didn't really talk about what the ACL did, but he found it in the knee. Took all the way to 1836. Um, the Weber brothers in Germany published this book that my friend told me correctly translates to the mechanics of the human walking apparatus. And They were the first to note two ACL bundles that are tensed differently during movement. And they noted that there was anterior translation of the tibia when the ACL is transected. First attempts at dealing with ACL injuries date all the way back to the late 1800s. Sir Robert Mayo Robson performed the first ACL repair, and he just basically sutured the ACL back into the femoral condyle. He followed his patient for 8 years, and you can actually read about his case report. This was a 41-year-old miner from Featherstone, admitted to a general infirmary at Leeds. Um, he was admitted on account of lameness from weakness and instability of the right knee from a work accident in a coal pit. So he fixed the ACL back to the femur, and at 8 years follow-up, he notes that no abnormal mobility whatever is present. Extension to the straight line is perfectly free. Flexion is somewhat limited, but the knee can be flexed to just beyond a right angle quite freely. In 1903, the first attempt at extra-articular stabilization was done by Fritz Lang, and basically they used silk sutures to treat what they called wobbly knees, and they noted that there's amazing potential for silk to develop fibrous tissue under functional stress. This wasn't didn't really work very well. The results were poor, and later efforts looked towards reconstruction with biologic tissue. Um, Ernest William Haygrove described the first ACL reconstruction using fascia lata autograft all the way back in 1917. He did a full-on tibial tubercle osteotomy, huge exposure to the knee, and he threaded a piece of the ITB from the lateral knee through the femur and the tibia. And I think it's cool because if you read his case report about his technique, he actually criticizes some of the attempts at repair of the ACL in the past, and he states that it is simply stated that previous surgeons um, repaired torn ligaments with suture. I confess that I find it difficult to understand this because in all my cases, the ligaments have been so destroyed or torn out from bony attachments that direct suture would have been utterly impossible. And of course, we can all relate to that to some degree, and that kind of speaks to the gold standard today, which is reconstruction. In 1934, Riccardo Galeazzi performed the first hamstring autograft harvest for ACL reconstruction. He had a tiny 5 millimeter tibial tunnel, and he left the graft pedicled to the pes insertion on the tibia. He put his patient in a plaster cast for 4 weeks and made them partial weight bearing at 6 weeks. It's amazing how much our understanding of this problem has changed, but it's also pretty amazing that all the way back in 1934, Galeazzi was doing a hamstring autograft ACL reconstruction, which people are still doing today. Um, this is the interesting part and relevant part of this talk is that when we talk about ACL injuries in the 60s to the 80s, extra-articular reconstruction actually dominated. And the reason for that is because we didn't have arthroscopic technique. Um, and there was a lot of different ways to do these extra-articular stabilizations. You can talk about many. There's papers from Lemaire at this time in 1967. He talks about the Lemaire technique, which would become the lateral extra-articular tenodesis, where we're harvesting the IT band and using that to stabilize the knee from the lateral side. And also, interestingly, you have this guy right here, James Nicholas, who published this article in 1973 called the 5-1 Reconstruction for Anteromedial Instability of the Knee. I had some mentors in back in New York who trained with Dr. Nicholas um, at Lenox Hill Hospital while he was taking care of some of the Jets. And long time ago, but it's our thinking has evolved a lot, but he was onto something here when we're talking about rotational instability. He looked at ACL injuries as injuries to the cruciate ligaments and the posteromedial complex, which imparts anteromedial rotational instability. And the posteromedial complex is the MCL, the pes tendons, the semimembranosus, and the oblique popliteal ligament and posterior capsule. Not really critical, but what he notes is that anteromedial complex instability is produced by valgus external rotation and flexing knee forces on the leg, which tears the posteromedial complex, the medial meniscus, and the anterior cruciate ligament. And he proposed this 5-1 reconstruction, which was all extra-articular to tighten up the posteromedial knee with a big open approach, big surgery. Patients were immobilized after the surgery, and uh, he did do this to quite a few professional athletes. And this is an article from the New York Times in 71 that after an operation staples ligaments to bone, patients go into a plaster cast for 6 weeks, and then it takes 3 to 6 months to recover power, motion, and stability. James Nicholas has operated on 76 jet knees, and his enthusiasm for such treatment, players call him Nick the Knife. So this is Broadway Joe Namath on the Jets, and he had a 5-1 ACL reconstruction. Um, I don't know if you've seen him, hobbling around but he's debatable how well that surgery really worked. This is a mentor of mine from residency, Reggie Manning at Kings County Hospital, and he actually had the 5-1 ACL reconstruction. And Reggie says they called it the 5-1 procedure because it had a 1 in 5 chance of success. And here we see young Reggie playing football for Stuyvesant High School in New York City, leading the charge with a 38-0 score. So, uh, you know, surgery worked okay for him. Um, so really the point here is that in the 60s to 80s, extra-articular reconstruction dominates because we don't have arthroscopy readily available yet. And the thinking here is that you leave the ACL alone and you stabilize the knee through extra-articular reconstruction. And this is the proper Lemaire technique where he took a 16 centimeter by 1.5 centimeter fascial autograft, left it pedicled to the Gerdy's tubercle, routed it under the LCL, and docked it back onto Gerdy's tubercle for that kind of 180-degree turn. You're starting and ending in the same place. And this Lemaire reconstruction is modified slightly to have a graft that's half as long, and you don't need to start and end at your Gerdy's tubercle. Why not just tack it to um, the behind the insertion of the LCL in the femur, and this became the modified Lemaire technique, and this is actually a lateral extra-articular tenodesis as we know it today. So uh, there's also, honorable mention to this Macintosh technique where, you could take hamstring tendons and actually wrap it around the femoral condyle and fix it to the femur or the tibia. And these results published were reasonably good. And the theme here is for, a lot of different tries have been made for these extra-articular procedures. And, we still use things similar to this today for in a lot of ways. My chairman in residency at SUNY Downstate, Bill Urban, actually had an over-the-top ACL at HSS, and he said that he was admitted to the hospital at HSS for 10 days, and he cried on day 7 because he wanted to leave so badly. So just amazing to think that in the 80s, people were admitted to the hospital with this procedure and oftentimes placed in a cast. Um, just a cool thing to think about. So, by the end of the 70s, coming up into the 80s, the thinking was that further comparisons with longer periods of time after surgical procedures are needed to determine whether extra-articular repair with intra-articular reconstruction of the ACL is better than the technically easier extra-articular repair alone. Um, Now we get into the age of really the modern way we think about the ACLs in the 80s and 90s when we start doing intra-articular autograft reconstruction. So the first BTB was done all the way back in 1963 by Kenneth Jones. He actually left the patellar ligament attached to the tibial tubercle, and then he docked the proximal part of the graft into the anterior femur because it was short. So extra-articular procedures kind of take over with the advent of the arthroscope. So by 1982, the first arthroscopic ACL was performed, and from there, it's kind of off to the races. James Andrews popularized the BTB throughout the late 80s and 90s. And this is a quote from him in 1991 that he believes, we were starting to think that maybe these extra-articular procedures were not necessary or even harmful, and they may over-constrain the knee and cause stiffness and pain. And James Andrews in 1991 said the trend is that with a high strength graft such as patellar tendon, we do not need a backup procedure such as any extra-articular augments. So these are some early studies from the late 80s and early 90s that show no difference with a good ACL BTB reconstruction, adding on an extra-articular stabilization surgery. The problem with these is that you can see they're using a lot of different surgical techniques for this extra-articular stabilization, and the numbers are very low powered. So these are low powered and heterogeneous genius studies. So tough to know how much we can actually glean from these studies. Um, James Andrews, of course, did a lot of ACL reconstructions on a lot of players that we know, including Adrian Peterson and lots of other people. And he was really a pioneer of that BTB autograft, which is still probably, I would say, probably still the favored graft uh, for high level athletes. Um, so, despite improvements in ACL reconstruction, people recognize that failures remain significant. This is a very good surgery. It's a great surgery, but it's not a perfect surgery. And in 2008, it was reported that 25% of ACL reconstructions had a persistent pivot shift on exam. And people were kind of looking at why do people fail, who's at high risk, and what can we do to help these high risk people, and people started looking again at some other surgical procedures because people thought that extra-articular adjunct procedures didn't work and may overly constrain the knee. So people started talking about double bundle ACLs, which was really uh, kind of brought to the mainstream with Freddie Fu at Pittsburgh. It's not as commonly performed today, but I think that this deserves an honorable mention in terms of the history of ACL because we're recognizing um, that the single bundle graft is not truly anatomic, and that we may be able to get some better rotational stability, perhaps if we have two limbs of graft instead of just one. But this hasn't been shown to correlate with better clinical outcomes. So, in summary, we have the first ACL repair done in 1897. The first extra-articular stabilization was done in 1903. Extra-articular stabilizing procedures actually dominated from the 60s through the 80s because it was easier and we didn't have arthroscopy. And then intra-articular autograft reconstruction took over in the 90s, and extra-articular stabilization fell out of favor. But there's notably high levels of failure after ACL recon, particularly in high-risk groups like young, athletic, and ligamentously lax athletes. So, how do we deal with these athletes, and how do we prevent this rotational instability and prevent failure? That comes back to the past happening over and over again. This is an article from the New York Times where these surgeons in Belgium allegedly discovered the anterior lateral ligament. This doctors identify a new ligament in the knee. Of course, Paul Sagan was turning over in his grave because he had talked about this almost 100 years prior. But this kind of brought this discussion back into vogue and got us talking about extra-articular augmentation again. So the thought is that residual instability and persistent failures renewed interest in extra-articular procedures like lateral extra-articular procedures. We're talking about ALL reconstruction, which was really popularized after the discovery of the a quote unquote discovery of the ALL in Belgium, and that kind of caught on in Europe, and the LET, which was rediscovered as a potential adjunct mostly in North America. So we talked a little bit about, how to actually do these procedures already. So I'll kind of skip this part, but in the uh, in the 90s and early 2000s, just to review, extra-articular stabilizing procedures were abandoned in the U.S. There was a lot of people from, high-powered institutions like SCOE and HSS that talked about how this could lead to increased stiffness and pain, but it continued to be popular in Europe, particularly in France and Italy, and that data was able to give us some long-term data out of the era from the 90s and 2000s, so we can kind of study how these grafts do long term. So, whenever you're talking about extra-articular augmentation, this guy Bertrand Sonnery Cotet always pops up, and the Santee group. Um, these guys are basically did a lot of the pioneering research in terms of how the ALL reconstruction works as an adjunct to ACL reconstruction. And what they said in their paper from 502 ACL reconstructions at 2-year follow-up from the Santee group back in 2017 was that hamstring, in conjunction with ALL reconstruction, was associated with a 3 times lower failure rate than hamstring autograft alone and a 2.5 times lower failure rate than BTB autograft. So people started kind of paying attention, but then some people said, okay, well, what about long-term follow-up? 2 years isn't that long. So they published this study in 2021 with 9-year follow-up, and ACL plus ALL showed better survivorship compared to ACL reconstruction, lower reoperation, lower revision rates, and less re-rupture, and but no difference in outcome metrics or Lockman tests. Then, a lot of Americans said, okay, well, we're doing BTB, you're doing hamstring. What about comparing just BTB? So then they published this, which was kind of an attempt to refute that head-to-head argument in 2022, and they had 1,009 matched pairs comparing BTB to hamstring plus ALL. And the BTB group showed 3 times higher risk of re-rupture and higher risk of reoperation. So 20.5% failure for BTB versus 8.9% failure for hamstring plus ALL reconstruction. Pretty striking difference. Not trivial numbers there, but this data has been criticized because we're not really seeing that 20% failure rate of BTBs here in North America. It's a little bit high. So, people kind of we take this data with a grain of salt. Um, the stability data comes out of mostly North America. Mostly this guy, Alan Getgood, who's practicing in Canada. And he did a lot of work while the Europeans were doing the ALL. He did a lot of work with LET, and he defines he was basically looking at hamstring or ACL reconstruction and ACL reconstruction plus an LET, and his inclusion criteria for high risk patients, he was looking at high risk patients, and his inclusion criteria for high risk patients were age less than 25 and any two of the following of a grade 2 pivot shift, returning to pivoting sports, or generalized ligamentous laxity. And he actually found similar findings that adding an LET significantly decreases your risk of graft failure and graft re-rupture and revision surgery. Again, not trivial numbers. We're talking about um, uh, graft re-rupture 11% for hamstring and 4.5% for hamstring plus LET at 2-year follow-up. So, what does the modern literature say now that we've been kind of, doing more and more of these surgeries for a little bit? Um, is there an easy procedure to prevent re-rupture in high-risk patients? Let's look at the LET. We now have some meta-analyses um, and some with some longer term follow up. And one meta analysis with 7 RCTs found that there is better patient reported outcomes with LETs. There is more stability on pivot shift exam, and there's 3 times less rupture with if you add the LET. Um, Another one found that there's no difference in return to sport, but there is a significant difference in re-rupture. And those numbers from the meta-analysis, or excuse me, from the RCT were 11.2% in ALL versus 4.1% in ACL, in ACL reconstruction versus 4.1% in ACL plus LET. So that's a really, almost threefold difference, which is the number that keeps coming up in the literature. Um, when we look at the ALL reconstruction, we have similar findings that ALL reconstruction improves stability when we look at the meta-analyses, 3 times less graft failure, but limited data that this can actually improve return to sports or outcome measures. So what's better, LET or ALL? I don't think we have data to say that one is better than the other. The Santi group in Europe will argue that the ALL is more anatomic and minimally invasive, and they advocate for that procedure. But I think LET is more common for whatever reason here in the United States, and head-to-head trials don't really exist that I could find, and biomechanical data is conflicting. So, how about the revision setting? I think a lot of us would look to do one of these in the revision setting. Um, Dr. Park talked a little bit about this in his talk. ACL revisions with extra-articular procedures improves failure rates. It improves post-op pivot shift exam. It improves high-grade Lockman, but it has not been shown to provide a significant difference with regard to return to sport or patient-reported outcomes. So when should we consider doing a lateral extra-articular procedure? This is some criteria that's been published, particularly by Alan Getgood from the stability trial. He looks at young patients under 25 who are returning to a pivoting sport, have a high-grade pivot shift, have global ligamentous laxity, defined as a Baton score greater than or equal to 4, and knee hyperextension greater than 10 degrees. So those are the people that he's doing an LET on, and his results have been basically uh, threefold less risk of re-rupture with that procedure. Um, Not surprisingly, the utilization of extra-articular procedures is increasingly steadily in the United in it globally. This is a Pearl Diver database study. In 2015, 0.6% of ACL reconstructions had leaps, and in 2023, 3.7% had leaps. So becoming more popular. That pendulum may swing again, but certainly there's some promising data behind this. Let's talk about some of the criticism as we kind of wrap up here. Um, People used to say that lateral extra-articular augmentation could overconstrain the knee and potentially cause arthritis. There's some early literature that does say that that could happen. 20-year follow-up in this study published in 2020 showed that BTB and LET was associated with higher risk of lateral compartment wear at 20-year follow-up, but that compared to BTB alone, but that group also had higher incidence of meniscectomy. So that's a, confounding variable that could certainly be criticized. More recent literature has shown that uh, in meta-analyses have shown that that lateral extra-articular procedures with an LET actually significantly reduce the risk of moderate to severe OA in the lateral compartment, but that's only 5-year follow-up, so take that with a grain of salt. Certainly, this is one of my criticisms is how are we doing this surgery? There's so much heterogeneity in terms of these studies. If you look at this study um, out of Stedman, these are a three surgeon study who described their technique, and they did some biomechanical studies to determine an isometric zone. And you can kind of see the point here is that their tunnels are kind of all over the place. Only when you're docking it into the femur, and only 50% were noted to be in this isometric zone that they found independently of the surgeons actually knowing about it. But the thing here is that even the same surgeon may have some real variability in terms of their tunnel placement. So why is the surgery so effective, and are we being overly optimistic about it? Um, Finally, we could talk about graft isometry. The LET is not an anatomic graft. So is there an isometric zone, and does there need to be? Um, I think we don't really know, but certainly it has me a little bit skeptical. There has been some attempts to diagnose an isometric zone on the femur that you can place this graft into. The isometric zone you can find radiographically by being posterior to the femoral cortex line and proximal to the proximal to the posterior femoral condyle line, and staying within a 10 millimeter distance to the lateral epicondyle. Um, but the idea here is that, this is a lot of variability in terms of how one surgeon may place the same graft. And, for anyone with experience with this, it's very, very hard to find a good isometric point for that graft in my limited experience. So we'll go back to our clinical vignette: young soccer player, non-contact injury, big pivot shift. Um, what would you do? I think we could consider extra-articular augmentation for patients with risk factors. The reality is ACL reconstruction is an awesome surgery. People do great, but sometimes they fail. That failure rate is somewhere between 3 to 20% or 7 to 30% for high-risk populations. And perhaps this is due to the need to control some rotational stability. Or kind of account for some patient risk factors. Some risk factors are not modifiable, like generalized ligamentous laxity, and others are difficult to modify, like posterior tibial slope. So, keep these tools in your back pocket for lateral extra-articular procedures. They improve ACL reconstruction, failure rates, and reoperation rates in high-risk people. I think we have pretty good evidence to say that now. Consider these surgeries in young, athletic patients who are returning to a pivoting sport. In the revision setting, in the ligamentously lax group, people with increased tibial slope, or coronal alignment that's a little bit funky. And that if we do these surgeries, we can improve rotational stability and improve stability clinically and biomechanically, and decrease failure rates, but not necessarily increase return to sport. This is a great paper about the history of ACL reconstruction if you're interested. Kevin Bonner has a really cool VUMEDI video on this topic that inspired a lot of this talk.